So, chronic Lyme. So, I have symptoms of chronic Lyme and my doctor won't treat me. We keep hearing this is the big complaint. My doctor's afraid to give me a lot of antibiotics because the college is going to be after him. Probably true. I saw one file where some guy was using chelation therapy to treat the chronic Lyme. At significant cost.
That's worse.
Sorry?
Trinitrophenol, that's what we use as well.
Nice.
Relatively toxic.
My symptoms are still available, are still present after antibiotics. Do I have chronic Lyme? And so there's the post-treatment Lyme syndrome, which is now CDC decided to have a definition. And the good thing about having a definition is for any surveillance activity, it's good to have a definition so at least we're all talking the same language. Because you have all sorts of people coming in saying I've got chronic Lyme and they don't have serology. So basically, you have a person who basically has a case confirmed of Lyme. So they had a serologic positivity and they still have symptoms that are persistent 6 months later. And these are some of the people where they've looked at, okay, does a course of antibiotics make a difference in this? And in fact, it has not been shown to be effective. So the question is, what do these people have? Is it another underlying disease? Is this an inflammatory cause? It's actually not known. And I'm always reluctant to, someone mentioned earlier, these are the malingerers. Because like many other things, some people get ill and there's a whole bunch of reasons why they recover slower than other people. And I don't know what the issue is. Is this because some people have a more vigorous immunologic response than other people do? We certainly see that with arthritis. We see that at post-surgical, etc. So I don't want to label everybody who has this as a malingerer or someone wanting disability. I think there are some people here have symptoms and are truly suffering, and the bottom line is we don't know what's going on. And I think we have to acknowledge that, and because of that, we essentially create a wedge where there are going to be people who are going to say, we have the answer for profit. And that's the reality. But that's the difficulty we face when science only takes us so far and patients still have symptoms. So just some things that chronic Lyme can be. Is it a post-Lyme syndrome? Is it something else? Is it just an antibody response? We know that women tend to make more antibody than men. So could just like any other disease, could the disease, for example, have triggered a seronegative arthritis? And that's what we're seeing. Any of these are possible, but I always find, how do you prove a seronegative arthritis? If it has a constellation, we'll say, yeah, it looks like RA, even though you're RA negative. So I think you have to keep this in mind, that there are probably some people that, whether it's a viral infection that triggers arthritis or a bacterial disease or spirochete, these are things that are also legitimate possibilities and probably more likely in women than men, because women tend to make more vigorous antibodies, and that's why women tend to have more inflammatory disease, such as lupus, etc., than men do. So the idea is, say, guidelines we mentioned before. Actually, I talked about this, about the whole challenge, so I'm not going to belabor this. And this is where the discrepancy between the various guidelines, and I mentioned here, NIH has funded 3 placebo-controlled studies for prolonged use, and none of them have been beneficial. So when patients say, I want prolonged disease, thanks. There's science that says it doesn't work, but other people say, no, I know people have been on this for 6 months or 9 months, and they got better. And we all know it was just like the role of antibiotics for viral illness, right? If you gave erythromycin for viral infection, patient got better usually in 2 weeks. If you didn't give erythromycin, they were better in 14 days. So if you have a long period of time, patients are going to spontaneously get better, independent of what our treatment is, and that's why we do placebo-controlled studies. As I say, the only thing with these studies, many of these studies basically focus on oral therapy. What we've suggested, if the government wants to fund it, we'll do a study with this using IV. But I want to do it with, I want to have not just pain markers and global markers. I want to have some psychology colleagues on board that we're working with behavior change. We want to actually look at markers of depression, and frankly, borderline personality disorder. I want to have those diagnoses and see if things change over time, because that's the one part of these trials that hasn't been adequately been looked at. So if we're going to be looking at it, let's start looking at for other diagnoses, because we're never going to put this baby to rest, because the advocates are not going to go away no matter how much science we throw at them. And I mean, again, people are suffering, and we can label them all we want, and I don't think we're going to have one single diagnosis for this. So good luck to you guys in primary care, because I really don't think we're going to solve this problem. On the PHO website, we have a whole bunch of resources on terms of lab diagnosis, and you can go on the analytics and you look at the interactive maps, and it will show you that you can look at the year and you can see what's happening in different regions around the province. Those are really cool maps. But the problem is not going to go away. In fact, the problem is going to get worse. The ticks are there. I will only agree with the CBC story in the one sense that Lyme disease is probably being where it's legit, is probably still being underdiagnosed in primary care, because a lot of individuals in primary care, if you don't see disease very often, or you see one, the likelihood you're going to nail that diagnosis, and if it doesn't come in classically, is going to be difficult. But the reality is that we're not missing as much, because once you get to the next stage, it becomes much more obvious. The testing is fine. I think we can stand behind it. The treatment works. And frankly, there's no evidence for long-term treatment, but we're going to keep being pushed to do that.